Today we're going to talk about Marfan syndrome. Oh, and we have a winner. Winner chicken
My
dinner.
little brother was
Do you have a Marfan
tested
here?
for it because he has all the symptoms of it. Doesn't have true Marfan.
He does.
I'll show you some parlor tricks.
Sure.
Yeah,
I don't
I'll show you
have
some
Marfan
parlor tricks
syndrome.
myself in a minute. And then we're also going to talk about familial thoracic aortic aneurysms. So lots of fun today. We're not going to be here the whole time. I know y'all get crushed when I don't take every second of lecture, but how much can you really say about Marfan and the other number one? And number two, I think we're kind of getting the gist and the hang of autosomal dominant, inheritance patterns. So all those types of things, I'm going to really kind of just gloss or not touch on it all because A, you can read your textbook. I know, I don't really want to do that either, frankly, because I think a lot of it is wrong. But you know, a lot of those terms are get used over and over again that we're seeing: penetrance, variable expressivity, all those types of things. So make sure you're paying attention as you're reading your text to some of those types of things. You know, so what variable expressivity means, penetrance, can you have 100% penetrance and yet have variable expressivity? Yes, right. Penetrance just means that if you have the mutation, you're going to get the disease. Variable expressivity means variation in the symptoms and the presentation of the disease, right? So things like that, just kind of make sure you keep straight in your mind. You'll see that type of thing again at some point. You know, maybe not, oh, is this type of disease or whatever, but again, just big general concepts I want you guys to understand. Okay. Marfan syndrome. My little history lesson for the day. Named after Dr. Antoine Marfan. Big surprise, he's the one who first described it in 1896. There's no cure. You got it, you got it. Just got to manage the symptoms and everything that goes with it. The good news is because our imaging and our surveillance and our medications are so good now, you know, a few decades ago, the life expectancy was only about 40 because of cardiovascular issues and things that went along with it. Today, it's pretty normal. As long as patients are being managed appropriately, are keeping up with it, you can have a pretty normal life expectancy, if not necessarily lifestyle, depending on what you like to do. Who knows about the Baylor basketball player? Yeah. So the guy was all set to sign, right? The NBA, like the night before or whatever. He gets the call from his doctor, diagnosed with Marfan. Nix. All done with basketball. So we'll talk in a little bit about some of the management has to do with your lifestyle, your exercise choices, things like that to kind of prevent either cardiovascular disease or aortic rupture and dissection, which is not how you want to spend your day. Okay, so pretty much Marfan has to do only, as far as they know, with the FBN1 gene, the fibrillin-1 gene. It's autosomal dominant. But about 25% of Marfan cases actually result from a spontaneous mutation. So not necessarily familial in the sense that a parent has it, right? It's a brand new de novo mutation. Affects about 1 in 5,000, 1 in 10,000 people. So here's a little phrase here: 100% penetrance, but variable expressivity. Right? So if you have one of these mutations, you're going to have the disease. It just depends on how it manifests itself. Fibrillin-1. So that's the protein made by the FBN1 gene. I think we've all gotten to the point of understanding that the mutations in the genes cause some type of issue with the protein, right? So in some diseases, it knocks out the protein altogether. Sometimes it just changes the composition or the shape of the protein, right? Sometimes it makes a protein that does something completely different than it's supposed to. Lots of different ways that those mutations can cause issues. But the issue is not just that the gene has changed, the issue is that then the protein is somehow changed. Okay. So mutation FBN1 results in an increase in TGF-beta, which heaven help me is one of those signal transduction proteins that you guys know I love so much. TGF-beta has a role in some way, somehow, they don't fully have it elucidated yet, but it plays a role in connective tissue and extracellular matrix. So TGF-beta and signal transduction has to do with cell growth, cell differentiation, and somewhere along the line, it does something with this. So extra points, I guess, in brownie points if you figure that out, but I'm not going to have crossed eyes figuring it out. So, but in general, fibrillin-1, the protein, links to other fibrillin-1 proteins. And when it starts linking, it makes these microfibrils, right? So just like our big cables that run all our other stuff, right? Creates these microfibrils. These microfibrils are an integral part of connective tissue. So that really helps keep that strength, the elasticity, everything together in that connective tissue. Some of the signs of Marfan. Long limbs. Bless you. And I'm not talking about, oh gosh, she's got really long legs. We're not talking about model legs here, guys. I mean, we're talking about differentially long limbs. So my dad and I have what my mother calls monkey arms. And we don't look all that weird. We don't have Marfan. Similar, we have lots of the signs and symptoms. We don't have Marfan. My father and I cannot buy regular long sleeve shirts. We do. They hit me about right here. I mean, I look like a 7-year-old that's outgrown my clothes when I buy a long sleeve shirt, so I just don't do it. That and it's Florida, it's hot. Yeah. Oh yeah, it's embarrassing. So that's a big tip off. Long, kind of spidery-like fingers. My dad has really long fingers, and my fingers don't look long compared to everything else, but they're kind of long and thin. Scoliosis. I have scoliosis. Nice little slight curvature of the spine. Flexible joints. Nice.
Awesome.
Oh yeah. Parlor tricks is what my son calls them. All 3 of my kids can do it too. So we sit around and try to gross each other out. You know, any other family members, if we're out and about, are freaking out and we're just laughing at each other. Here's one other good one for you. The arm goes all the way around. So ask your brother if he can do all of those.
I know he can.
Oh yeah.
His favorite party trick is to stick his hand backwards and grab your shoulder. Almost his elbow to the opposite.
Oh, that's cool. I can't do that. Oh, I'm gonna have to learn that. Actually, I think I'm too old and inflexible muscle-wise to do that. Crowded teeth. So, you know, I've spent like 6 years in braces and all kinds of retainers and everything else because I had no room for my teeth to come in. I was 16, my 12-year-old molars still weren't in. They finally had to go in and take the wisdom teeth out for everything to move to come in because there's no room in there. Everything's kind of squished and crowded. Chest deformities, either it's concave, convex, those types of things. Unexplained stretch marks. You have 3 kids. They're all explained. But in general, because the tissue is just very stretchy, very elastic, that kind of thing. So those are the things you can really see from the outside. And it's tough because it's children and they're growing fast and they're growing quickly and everybody looks different at little ages anyway. And again, with the variable expressivity, sometimes you just don't know. You're looking at someone and you think, So you start looking for, especially the flexible joints. My parents first noticed that in my school dance or my dance pictures, ballet pictures, recital pictures. Where you're doing the little pose or the gymnastics pose, and my mom goes, "That's not okay," when the elbows are like this. On the inside, some of the big issues, however, are cardiac issues. So I had an echo a few years ago, and that's when they're like, okay, we're not worried about you anymore. But a lot of these patients wind up with mitral valve prolapse, right? Because what are those valve cusps made out of? They're made out of connective tissue, that's right. So if they get floppy and aren't opening and closing well, then you're going to see regurgitation, valvular insufficiency. So valves have 2 jobs. They got to open and they got to close. That's it. That's all they got to do. But if they can't open well, then obviously you're not getting blood through to wherever you need to get through, right? That's not typically the problem with this. The problem is the fact they don't close well because they're just so floppy. So blood starts leaking back in, right? So for example, aortic regurgitation, that's definitely a problem because it's leaking back down into the ventricle, right? So patients wind up getting short of breath, fatigue, they start getting heart failure, same with mitral insufficiency. Ocular disorders. So they get myopia. They're really nearsighted. That's definitely not my issue. And they're at a much higher rate of risk for retinal detachment and lens dislocation. Something like 60% of patients with Marfan wind up having a lens dislocation. Sounds not fun to me. I don't like anything with my eyes. So diagnosis. Like I said, most of these cases are familial. They have a family history. Parent has it. Somebody along the line has it. My pediatrician has been looking at all 3 of my kids, just making sure, listening to their heart every time, making sure there's no murmurs, no clicks. As soon as each 3 gave him their parlor trick, it's on the radar. But then also on physical exam. So aortic dilatation, I'm going to show a lot of good pictures of that when we talk about the familial TAD. So I found some cool stuff on that. Ectopia lentis, the lens dislocation. Dural ectasia, so a nice little sac around the dura and the spine. And then 4 of 8 skeletal features. And those are in a table in your book. And I'm not going to, let's say for the test, I'm not going to go through and find really obscure skeletal features. But as long as you know there's things like scoliosis, joint hypermobility, those long fingers, long limbs, that's the kind of stuff I want you to know. It takes too much effort to look for really stupid things to test you on. Nobody's got time for that. Okay. Well, some professors may, but they shouldn't. They need a hobby if they do. Okay, so. And don't go tell your most unfavorite professor I said that. I'll never. I will not be asked back.
We don't talk to her.
Okay. There you go. Okay, so if you have Marfan, your child has Marfan, your patient has Marfan, who should be involved? Well, this is one of those things where a treatment team, an actual team approach, works very well for these patients because they do have so many potential things that go on. And like I said, the life expectancy can be pretty normal as long as patients are managed appropriately. So make sure you have people on board, educated people about Marfan on board. So they should really have a geneticist or a genetic counselor, right? Of course, this is definitely something that can be inherited, and with 100% penetrance, if your kid gets the gene, they're getting it, right? An ophthalmologist. So they should be seen at least yearly by their ophthalmologist, more if they can see things that are starting to happen in there. A cardiologist. So patients should really have an echo every year if they have Marfan, especially if you're looking for potential aneurysms, mitral valve prolapse, those types of things. So really good echo tech will also be able to find the aortic root dilatations and stuff like that. If you get to the point that you need it, you're going to need a CT surgeon, a cardiothoracic surgeon. So if you have the aortic root dilatation, you have aortic regurgitation, if the mitral insufficiency gets too bad, any of those things, then you're going to be on a table in my hospital. And obviously an orthopedist, between the scoliosis, which can be progressive for these patients, and then joint issues, because let me tell you, I'm 40 and my knees hurt already, because just like these go backwards, so do my knees. Yeah. That doesn't feel good when you're playing tennis. So those types of people should also be on board to make sure they're checking on patients. Management, what are we doing for these people? Why do you think they need beta blockers? You got it. You want to keep their hypertension down, right? You want to keep the pressure as low as possible, pushing through the aorta. Because the ventricle is pushing, and where's this coming? It's coming out the aortic valve, up through the aorta and around, right? So if you have connective tissue that's weak, what are you going to get? Rupture. So probably start with an aneurysm, and then potentially you're going to have rupture. Do most people have symptoms with an aortic aneurysm? You got it. So very rarely, unless it just gets to this big size that is pressing on something, do most patients have symptoms until something bad happens. And we'll talk about the bad stuff in the next little lecture. But you don't want it. So beta blockers are pretty important for these patients. Lifestyle education. Should these patients be smoking? No. Exercise, just like the basketball player. There really no isometric exercises. Diving, like scuba diving, anything that's going to change the pressure in your body. Like I said, isometric exercises where you're pushing and holding, you're using your own strength against stuff, can be dangerous for these patients. Then we talked about the smoking. Medications. It's really important to be careful with decongestants, caffeine, anything that's vasoconstrictive, because you're increasing the pressure and putting more pressure on weakened aortas and other weakened arteries. The other thing you need to manage, especially with women, is pregnancy. So women that are much higher risk for an aortic dissection, because of course their pressure's gone up, right? And their blood volume has gone up. So there is a lot flowing through these ladies at the time. There's a lot pushing on their walls. The other thing that they don't mention in the book, I don't think there's a lot of information out there, but women could be at a higher risk for early rupture of membranes. So I found this out because my second child was born at 35 weeks, and I'm in the doctor's office afterwards, and we're talking about what could have happened and blah, blah, blah. And I happened to mention something about my hypermobility, and he goes, really? And I said, what? And he said, you know, there's some evidence out there that patients with hypermobility may be at higher risk for membrane rupture. I don't know if there's a lot of papers or studies or anything done, but that's something to keep in mind, which makes perfect sense because what's holding all of that together, right? Yeah, so that's just something to keep in mind for those patients. Probably have to worry more about aortic rupture than that, but either way, if you get the mom through it and something happens to the baby later on, it's still not a good situation, right? So as I said, these patients should get an annual echo, like checking their valves, looking for valvular insufficiency, seeing if you can see any aneurysms around the aortic root. And then of course, if you are known to have an aneurysm, then a lot of surgeons will want a CT scan annually, at least every couple of years, to check on the size of that aneurysm. So I know in my surgeon's office, in my CT surgeon's office, because one of our guys does endovascular thoracic repair, which I brought some goodies to show you guys on in a minute. But I know they keep pretty close tabs on those patients, especially as it starts getting, 4 to 5 centimeters. They're going to be keeping a close eye on those patients. And that's just in general for having an aneurysm, not necessarily Marfan. All right, questions on Marfan? Because how much can you really say? None? All right, cool.
Are they recommended to not have babies or just
No,
be closely watched?
Just be closely watched. Okay. All right, familial thoracic aortic aneurysm and dissection. Okay, so the familial type of this disease causes about 20% of all thoracic aortic dissections. And thoracic aortic sections kill about 30,000 people a year. We see them. We see them in our hospital. We had one last Thursday flown over from Gulf Coast. I think one of the really sad things about aortic dissections is a lot of times it's seemingly healthy people, right? I guess it was a year or two ago, big strapping healthy firefighter here in town went down with a dissection. I mean, it was all the firefighters in town were in the hospital. You just never know. It's just sad. It's like Jack Ritter, I think he had the AAA, the abdominal one. And it's just bad. So familials had, it's about 15,000 deaths per year. These are from different sources. And only less than 50% of people who rupture will live. So it depends on where you've ruptured, how big the rupture is, how quickly you can get help, how quickly you're bleeding out, all those other things about whether you will live or not. It's bad stuff. All right, so quick anatomy here, right? So we're talking about the ascending aorta here, and then back behind, down beneath goes the descending aorta. And then we got the arch with the 3 arteries coming off it. So we're talking, this goes down into the aortic valve. Just so everybody's on the same page here. So we're talking anything that starts right around the sinuses of Valsalva, just above the aortic annulus, up through the ascending, down into the descending. Once you get to this abdominal aorta, that's typically when the general surgeons will take over that case. Up in here, you're going to have your cardiothoracic surgeons who are going to deal with most of that. Alright, so continuing on anatomy, the layers that make up the aorta. You guys, I know you know those, but you have the intima, which is the inner layer, and it's made of endothelial seals, apparently. Okay, at least it's not eels. But, so endothelial cells. You have the media, which is the middle. This is mainly smooth muscle tissue. And the adventitia, which is made of the connective tissue on the outside. So a lot of times what starts happening is you start getting a slight tear of the intima, and as the pressure is going through it and the blood's pushing and pushing, right, the tear just kind of continues on into the smooth muscle, continues on into the adventitia, and then it's bad news. And we've seen them where they have ripped from, I mean, pretty much the arch all the way down. So, you know, sometimes we're talking about a small tear, and sometimes we're talking the whole thing's pretty much blown. So there's different types of dissections. So A and B are type A's. They're in the ascending. C is a type B in the descending aorta. So you guys see the little rips, right? Little tears, tear, tear. So there's type A and type B, then there's also what's considered like a DeBakey class, right? Or class A, class B. So this would be, A would be a type 1, B is a type 2, and C is a type 3. And I've heard surgeons use all the different nomenclatures. I've heard, oh, we've got somebody coming in with a type A dissection. So they know it's in the ascending, but they haven't seen the CT scan yet to know exactly where it is, right? Or, oh, we've got somebody coming in with the class B. And that's where they're looking at, is in the descending.
What are type 1 and type 2?
Where it's located in there.
And then D, what is D?
D, I believe, is just, it's an example of like a tear on either side, on both. So this is a CT scan that I pulled off. And, okay. So we're basically looking almost down into the valve, right here. And so what you're not seeing is how the arch has come back up and around, right? We're looking at it across section. So you can see a tear here. And as it's going back down, you can see a tear here. Thought this was a pretty cool picture too of a CT. Look at this aneurysm. So that was a dissection, right? This is a picture of an aneurysm. this right here is the aortic valve. You can't even really see the third cusp. So the cusp of the aortic valve are like three little round humps at the bottom. The leaflets, you can see them. So we're looking at the aorta, sinus is about salva here, okay, left ventricle obviously, and coming off this side here, off the non-coronary cusp, is this massive aneurysm. If you do the 3D reconstruction, there it is. I mean, that thing is, what, 3/4 the size of the ventricle? That's pretty big. That's a pretty cool picture. Yeah, that's going to be surgery. That's going to be open surgery to replace the aortic root and the aortic valve for that. This is a picture of what one might look like on echo. I am not great at reading echoes. Gotten better, but. So you're looking at the right coronary cusp, left, and then this big aneurysm hanging off. You're not even looking at the non-coronary. Right ventricle, pulmonary arteries over here. That's just huge. Okay, so what does a dissection look like when somebody presents with a dissection? Chest pain. These people, yeah. These people are coming in with pretty severe, usually sudden onset chest pain. A lot of times it's radiating to a shoulder, most likely the left shoulder. You know, it's got all those kind of heart attack almost presentations, right? And a lot of patients also present with the 4 Ps, which made me evilly giggle a little bit because, well, yeah, surprise, pallor, pulselessness, paresthesia, and paralysis. You're not getting blood anywhere. It's all pouring into your thoracic cavity, right? So, pallor, obviously, you know, they're pale, not getting good perfusion anywhere. Pulselessness, big surprise. You know, if you don't treat it, they're going to be terminally pulseless. Paresthesias, again, you've got numbness. I mean, you're just, and paralysis. So, the last couple of ones, though, can sometimes make people mistake this for stroke. Right? Especially you're looking at someone, they seem fairly healthy, something's going on, they're talking to you, but yet they've got some paralysis issues going on. But especially for young people, the first assumption would be pulmonary, right? I mean, you have someone y'all's age, my age, you go in with chest pain. All chest pain is what? Until ruled out. It is angina or heart attack until ruled out. But you have a lot of people, like me, because I've done this, who have had chest pain and not gone to the emergency room because you don't want to look like an idiot. Exactly. There is a case of one of the cardiologists in town, his sister, whose dad is also one of the oral surgeons in town, super healthy, she's a vegetarian, she's a runner. I mean, this girl's tip-top shape. She's visiting her parents' house one day. She lives here in town. She's over at her parents' house, and she's like, I just don't feel good. Something's just not okay. I just don't feel good. I think I am getting the flu or something. But, you know, dad notices she just doesn't, something's just off. So he calls her brother, the cardiologist, and of course he says, she's too young to have cardiac issues. She's, you know, early 30s. She's, like I said, she's vegetarian, she's a runner, she's fit, she's super in shape. she's fine, she's just getting sick. And she keeps saying, no, she doesn't want to go to the emergency room. And then she starts getting really nauseous. So, you know, all of those things that kind of go into, for a woman, can be different for a heart attack, right? A lot of times for women, it feels like they are getting the flu. Eventually, she's just not good, and they take her to the emergency room, and she was actually having a coronary artery dissection. And for her, come to find out, this is something, she's had two, I think since then as well. But those are the types of things that you have to look for, because nobody would have thought originally that she came in that she's having some type of dissection. So they did an EKG on her, things were off, they rushed her quickly to CT, they can see the dissection, oh, you know, so off she went to the cath lab and they stented her and she's okay. But a lot of times for young people, especially it's a pulmonary, they think, you know, got some pleural things going on, especially during season, right? Everybody's coming in with bronchitis, that type of thing. But I guess if you're coming in with pulselessness, you might think otherwise. All right, so we'll get through this and then we'll take a quick break. There's not that much more. All right, so there's 4 genes that the book talks about being involved. There's actually more than that, but these are the ones that are in the book, so these are the ones we'll stick with. The ACTA2 is the main gene involved in this. It's about 14 to 20%. The TGF-beta receptor 2, about 2%. Be careful when you're reading the text in this. I found it very confusing when they were talking about ACTA and then she puts the dash and she talks about loci. Loci is where the gene is found. And at another point in the thing, she calls one of those loci a gene. But that's not the gene. So don't memorize that terminology in the book. When we're going to talk about the genetics, anything for the test, the genetics part of this, go off of what I'm saying and what's on my slides, okay? Because I didn't like the way that was worded. Maybe it's just me, but. Okay, so TGF-BR2, TGF-BR1, what do you guys think that is? We just talked about it with Marfan. The TGF-beta. So this is the receptor. Yep. So familial TAD can have a component or have a mutation in the receptor for TGF-beta. So again, it's the same thing. The other one had to do with actual TGF-beta. This one's going to have some issues with the receptor. Again, how that is actually all involved in connective tissue is not elucidated, but there's a connection with the connective. Again, this is autosomal dominant. The ACTA2 gene, like I said, accounts for about 14 to 20% of familial TAD, so quite a, you know, it's a decent amount. The mutations that are in the ACTA2 gene wind up with single amino acid mutations. So there may be point mutations, maybe a translocation, whatever it is, but all it results in is a single amino acid mutation. All the known mutations in ACTA2. Which amino acid, I don't know. I'm assuming it must be several different ones, but. So ACTA2, what it does is it codes for, I guess it doesn't make it, codes for alpha-2 actin. And that's one of the proteins that's found in smooth muscle. So alpha-2 actin binds together, makes the core of sarcomeres. So when you have a mutation in alpha-2 actin, the muscle can't keep its shape. Okay, so especially as blood is rushing through it, pushing through it. It's like blowing up a water balloon. Okay? It's gonna get weaker and weaker and weaker as it gets pushed on. So that's why alpha-2 actin is important. All right, let's take a 10-minute break and then we will finish up with TAP.